Hello to everybody. As Sabina Nuti speaking now, I'm very happy to open this session regarding COVID-19 and how Italy is facing this very incredible emergency that we are going through all over the world. This roundtable has, I think, the most relevant person that now in Italy as we are working on this issue. So I really would like to thank all of them for trying to find the time available to participate to this meeting. First of all, I would like to give just a couple of minutes to Nick Ladzinska, that is the scientific responsible for this Marie Curie project in HealthPros, just to introduce the afternoon. Please, Nick, if you want to just welcome and start the meeting.
No, thank you, Sabina, and welcome to, of course, the fellows, other participants, and very much so for the speakers of this afternoon, because I fully realize that you're very busy at the moment for dealing with the pandemic in Italy. A lot of thanks. As you know, the context of this lecture is in a part of a Marie Curie intensive training network, the HealthPros, in which we are training a series of 14 fellows in a period of 3 years to become experts in the field of performance intelligence. And they are all doing projects related to measuring performance, how this information is used in the governance, and how it's actually applied. Of course, I first sympathize with everybody who has direct impact of this crisis, and especially if your family or relatives are infected and suffer some of the consequences. On the other hand, as scientists, it's also an extremely interesting natural experiment that is really shaking up our healthcare systems. So there is a lot to learn on how health systems respond to this pandemic, and basically see in the different phases of the pandemic what kind of things are set up. I'm also working from the Netherlands and collaborating with OECD and the World Health Organization has not become a reality in the past decade. So I see that the governance of the healthcare system is strengthened. You see that there is far more involvement of government, even in systems where you have a large private component, like in Australia and Ireland. We've seen that the government is taking charge. We see the need of capacity management, not just creating new capacity for things like protective materials, tests, and ventilators, and also health personnel, but also very difficult decisions about rationing, about how to distribute the existing capacity. And last but not least, we see that there is a crowding out. Of course, the rest of the healthcare system is still functioning, and we have to address the pandemic when other things are going on. Then you can only postpone things for a certain period. So I'm sure that the impact of this crisis in the countries that are affected, and especially within the European Union, will give us a lot of lessons. And one way of learning about what we're doing is having these kind of sessions, where we take the time to hear what is actually going on and try to reflect what that means in terms of having new ways of governing, measuring, and monitoring what's happening in our healthcare system. So thank you very much, and I'm very much looking forward to hear the presentations and the opportunity for the fellows to pose their questions to really understand in this crisis situation what can be learned from the responses, and especially from the data infrastructure that is needed to guide governance in this moment.
So thank you, Nick, very much. And so we will start now with a very brief presentation by Professor Milena Vainieri. She will just give some information and some data regarding the Italian situation at the general level. And then we'll give the floor to Walter Ricciardi. It's a really important person now in Italy in these days, particularly because he is the consultant of our Minister of Health. He is a really important expert on health policy and on also working on this type of topic. He has been part of the expert panel and investing in health systems, and he is going to be with us until around 10 to 3. So he doesn't have a lot of time, but he's going to give his point of view, and then he's going to be available for a few questions at the end of his very short presentation. But I really thank him to be with us because he is very, very busy during this period. So please, I give the floor to Milena Vainieri to introduce the topic.
Thanks. Just 3 minutes. I won't be more, just to provide you some basic information. So it's not comments, just to provide the timeline of the Italian national response to the COVID outbreak. So it started, let's say, at the end of January. Italy set the state of emergency, so they stopped the direct flights from China, and we had the first few cases at the end of February, the 23 of February. We had the first lockdown of some areas from Veneto region and Lombardy. Then 1 week after, we have the extension of this lockdown also to other provinces. The 4th of March, we closed the school and university in all the territory in Italy, and it was supported also the smart working. The 8th of March, the lockdown was extended to the whole territory in Italy. And then, as you saw, progressively, we closed also the retail businesses, as bar restaurants closure, and the 22 of March, there was also the closure of non-essential business and industry. And there is also more restrictions to movement. Then, let's say, which are the other points to be highlighted. So, really fast, we have task forces at national and regional level. The civil protection increased to have a higher role because of the emergency state. There was also the Istituto Superiore di Sanità and the Spallanzani Institute that have an important role also in providing support to the Ministry of Health and the whole regional health system. We have a scientific committee that support the decision of the government, Italian government. We have had also a special commissioner. In March, it was appointed a special commissioner to purchase the personal protection equipment. And another interesting part was that there was a daily communication every day at 6 p.m. There is the situation, the fact sheet, let's say, communicated by the Prime Minister. And then all these data are available on a web basis from the civil protection. These are the numbers, so the evolution of what happens in Italy. In yellow, the total cases of COVID. In purple, you have the number of cases that we have now. You have the number of deaths in red, and in green, you have the number of people that recovered from COVID. So the other thing to be highlighted is that there is a wide differences across the regions. You know, the more affected regions are Lombardy and Veneto, but then we have also Piedmont, Emilia-Romagna, and so on. These are the numbers of hospitalization people with COVID. As you can see, it's interesting that we are now, it seems that now the decreasing is slowing. And this is a picture that reminds you the different path of some regions. So here you have Lombardy, you have Veneto, you have Piedmont, you have Emilia-Romagna, and you have also Apulia, one of the regions that of the south that were affected after from COVID. And other 2 points are related to 2 of the key issues that are discussing in this period. It is the diagnostic testing. So this is the number of tests, diagnostic tests that were run in Italy since the beginning, with the different degrees, the shade of blue of the number of testing that were run across the regions. And again, differences also, this is Italy on a total basis, more than 500 of tests, diagnostic tests were done, and this is 100,000 of testing were done in Veneto and 121 in Lombardy. And the other part was, the other important part that is discussing was also the bottleneck of the intensive care units bed. So we show here in this graph, these data were drawn by the web platform of civil protection, and they were elaborated by our group of research. So thanks to Mimo, Antonio, and the others that collected and provided also these graphs. So the number of beds per inhabitants and the number of occupancy rate of EQ bed in this period. So just to provide wider picture of what happened now until now in Italy in terms of key numbers. So I stop here because I want to leave the floor to our guests.
Thank you very much, Milena, for this nice presentation that gives you a picture, gives us all a picture, and thanks to the over 70 persons that are connected now. And I just give the floor straight away to Walter Ricciardi. Thanks for finding the time to be with us today and to comment on this incredible situation we're in, and give us some advice on how Italy is approaching this emergency. Please, Walter.
Yeah, actually, my experience with these hours as a public health physician in January, when everybody was looking at China, of course, as a source of contagion. And at that time, as a simple professor of public health, I strongly criticized the decisions of the Italian government, particularly the one that blocked the direct flight from China. Then what happened is that I am the Italian representative in the WHO Executive Committee, and on the February the 3rd in Geneva, we had an executive committee fully dedicated. You must know that Italy and China are at the moment countries in the executive committee. So I had a chat with the Chinese representative that was somehow shocked, because at that time the only countries that blocked the flight to China were the United States and Italy. And he said essentially we wait this decision from USA, which are certainly not our friends, but we didn't expect that from Italy, which in the last times is a friend of China. And I said, I cannot take responsibility. This is a silly decision. So I have said that. So when I was back in Italy on 4th of February, I mailed the government saying, you have to take evidence-based decision. This didn't happen. I was in a TV show on the 22nd, and again I criticized the government. And on the 22nd night, I was called by the government, and particularly by the Minister of Health of Italy, which I didn't know. And he said, please, can you help us in providing advice? And so my collaboration started on the 22nd, and I can tell you that from the 23rd, an evidence-based decision-making process was started in Italy with some of the best possible scientists which I called in the group, called to collaborate and to provide the government with the most up-to-date evidence coming from China, of course, at that time, but also from the experience that some of us, and I had in the previous pandemics, namely the SARS, the MERS, and the pandemic flu of 2009. I can tell you that on 2 days after we called a meeting with the ministers of health of the neighboring country of Italy, plus Germany and Croatia, which is the current president of the European Commission. And together with the minister, we urged the ministers of health of taking action, because we warned them, this happened on the February the 25th, that this was a serious event, but actually we weren't taken seriously at all. At that time, Italy was considered a poor country experiencing an outbreak, an Italian business. Again, I pushed the minister to call for a meeting, for a special meeting of the ministers of health of Europe the week after, because in the week, many countries were affected. And so the ministers of health started to realize that it was not only an outbreak limited to a country, but that could be seriously becoming at least an epidemic spread at European level. And essentially what happened is that even in that arena, we weren't taken too seriously. And essentially when we say that we'll lock down at least part of the country and eventually where we're going to lock down the rest of the country, they took it as extravaganza. You know what, this is too much. You cannot understand that there are economic reasons, you know, that this cannot be serious. Then another week was spent in debate, and then luckily, and actually very lately, all the European governments and also the European Commission took it very seriously. What I want to say is that it is incredible how this situation has been underestimated and underevaluated. You know that we as public health people, and particularly the people that are experiencing the infectious disease, and take the opportunity to say hello to Nick Lazinga, my old friend, and with some people from the Netherlands, we have spent most of the time warning the world that a pandemic was sooner or later happening. We weren't taken seriously, but moreover, a guy like Bill Gates was not taken seriously. Now we experience the worst possible scenario, because honestly speaking, luckily, this is a virus which doesn't have a case fatality rate very high, luckily, but almost the worst possible scenario, because it's a virus which is transmitted via respiratory system, which means that it's enough that you stay close to a person less than 1 meter, you speak with this person, and with the voice or with the cough, you are infected, or maybe you are infected with the hands. And so everybody is susceptible. All the people on the planet Earth are susceptible. So now we have to face, this is a very, very serious challenge, and that left alone can really infect billions. I think this is going to change the world. Scientists all over the world are working together, and essentially we exchange ideas. I've never seen before such a collaboration. Of course, a collaboration has always been present between scientists, but now it's very organized, it's very structured. There is one conference a week for scientists and scientific advisor to governments. There is one meeting a week with ministers of health of the European Union. There is one meeting a week with other members of the cabinet. There is one meeting a week with the European Commission. So the world is really mobilized in order to fulfill this need to find a care and to find a vaccine, which is the only way that we can go back to the old normality. My opinion, and I'm going to close, is that, of course, there will be a time in which we have to live with this virus, as we live with other viruses as well, but essentially managing a better way. Certainly, lockdown cannot last forever. We have to develop an incredible and quite precise strategy of testing and, of course, of tracking, also using technological tools, because manual tools are not enough. to test the thousands of people that can be infected and can have a contact with other people. And this is something that, again, we are trying to develop together. Italy is working on that, but Germany is also, and France is also working on that, and I guess that other countries will follow this path. So I'm, of course, optimistic that sooner or later we will find a way in which we can take care of this virus in a more specific way, and in 12, 18 months we can develop a vaccine. Up to now, it's very important to exchange experiences and idea between public health people, epidemiologists, infectiologists, economists, service researchers, managers, politicians, and I really believe that it's only with the collaboration with these two pillars, science and politics, and of course the different disciplines in the scientific world, that we can really win this battle. I stop now, and I'm very happy to answer to your question.
Thank you, Walter. You were very clear, and I will ask Anna Maria if you want to present to Walter some of the questions that the fellows from HealthPros thought to ask to Walter Ricciardi.
Professor, there's 3 questions that we selected for you from students. What information did you need or wish you had but didn't have access to? How does this information need changes with time? This is the first one. Okay, the second one, Italy was the first Western country to institute a lockdown following China's response to the crisis in Wuhan to contain the spread of COVID. Given the cultural and political differences between the two countries, what was the main deciding factor that prompted the government to make this decision action? And the third one, are there differences in government approaches needed between regions with a high proportion of independent sector providers like Lombardy and those with a more public system? In a situation like the COVID pandemic, are the formal governance levers actually used, or is it a more collaborative approach?
About the questions, first, of course, this is a new virus, and we lack a lot of information from the microbiological point of view. And of course, we have to generate a new flow of information, and this is not easy because the diagnostic tests that we have now are difficult to execute, are time-consuming, are very much dependent on people. So we now are all the world is trying to develop new information, in particular about serology, which is going to be the only way that we can better understand how the virus has spread into population, what kind of immunity has the people developed. So this is the most important information that we lack. And as soon as we will have it, and just yesterday, all the countries in the world have decided to do that, the sooner the better. Of course, we still have to wait for a very sensitive and very specific test, a serological test, but I'm sure that in a relatively short time we will do that. Certainly, it was a challenge to do a lockdown in Italy, so the first democratic country to do that. Actually, the Italian people, the vast majority followed us, and still now there is quite not surprising, but certainly persistent participation by the population to do that. Of course, there is a minority that has to be controlled, and the law has to be enforced. But up to now, with the massive also persuasive campaign that government did, and also support of media, it seems to, and we still have to, because in my opinion, this will at least for 1 month. And the problems has been the governance. In Italy, we have a national service which is regional based, and so politicians, even though I encourage the central government to act, in the constitution there is this prerogative for the central government to call for special power in time of epidemics, is an explicit article of the constitution that say that this is possible. Politicians were reluctant to act this. And so the decision-making process was to find a compromise or something which is acceptable to all the presidents of the 21 regions and autonomous provinces. I just had a very few hours ago a meeting with top politicians in our country, and again, they don't want to do that. They are reluctant to take these actions, but to my push and encouragement, they will take some central actions that will be important to differentiate the measures. I have used the example of a war, and for instance, in Lombardy, we have to use bazooka because the circulation of the virus is still terrible, while in other parts of the country we can use knives. Up to now, we have used bazooka for the whole countries, and if we want to get out from the situation and to go back to some form of, new abnormality, we have to use the test, the tracking and containing strategy, but also to differentiate the measures according to the specific needs of the regions. This is not only an Italian problem. Spain had the same problem. I have just heard that the Catalanian government is going to be rescued by the military, by the Spanish army, because they are fully unable to fight the disease in Catalonia unless they are supported by the army. This is the same in Germany, where they have a federal structure of the state, but as far as I know, the central government, in particular the Minister of Health Spahn and the Minister of Interior, achieved some form of centralization, so some derogation to the federal structure of decision-making. I hope that I replied to your question.
Thank you very much. I think if there is just perhaps, Walter, time for just another question, if somebody wants to add something in the chat.
Yes, please. I can stay up to 2:50.
And also, Nick, if you want to do a question to Walter, please, the microphone.
This is Nick. I thank you very much, Walter, for your presentation. My question would be, could you share a little bit more about your test and track strategy and how that would evolve? We see now many systems that are, well, there's a lot of work on the capacity of the testing. We can expect that over the coming month, in many EU countries, more tests will become available. As you said, both testing the virus serology. For both of them, we have some doubts about sensitivity, specificity. So how do you assure, in the Italian situation, but also broader, that tests will be used appropriately and that we will have a real targeted test and track strategy?
Yeah, thank you, Nick. I think that we have to differentiate between the molecular testing, which is the accurate, specific, and sensitive testing that it is used now for diagnosis, and the serological testing that is going to be used for checking immunity. As far as concerned, the first one, now the problem is medical equipment, in particular the reagents that are needed to execute this test. But I'm sure that this capacity will be increased by manufacturers, and this could allow us to test in a more extensive way. What I mean when I say more extensive way is not making tests to all asymptomatic people, but only to early symptomatic people, to three categories of people. First is the early symptomatic people. So test as soon as there is the onset of even very mild symptoms. So cough, so not wait 3 days to be tested, but at very beginning you should be tested. That should lead to a check of positivity, and in case that this positivity is confirmed, we should be using the technological tools that we have for tracking and to get in touch with all the contacts that have been in contact with the positive case, and to track them down and then to quarantine or to isolate and eventually to test them in order to limit the spreading of the disease very early. So this is the first approach to testing. The second approach to testing is for people that get out from their symptomatology. So in other words, of course, this is already done in hospitals. When you have no more clinical symptoms, to be discharged, you need 2 consecutive negative tests at the distance of 24 hours each. In case that, and this is the most frequent case, that people stay home during their disease, they frequently go back to civil or to productive life without any check. And this has been shown to be very dangerous because in many cases, they are still infectious and contagious. So the second category to be tested are the people that spend their disease at home before being admitted to any kind of civil or productive life. They have to be tested at least twice to consecutive way in a distance of 24 hours each test. And the third category to be tested are healthcare personnel and essential personnel such as police or fireworks, etc., because they, in particular, the healthcare personnel has been shown, particularly in Italy, to be an important source of infections. All of the activity has to be followed by technological tracking and by the release of a kind of digital passport for immune status that each single individual can have. This can be complemented by the serological testing. Whenever we will have a good, sensitive, and specific test, we could test a vast amount of the population and then to release a kind of immune passport status to people that can go back to factories or to productive life. I only see this kind of approach as feasible to allow countries to go back to a certain new abnormalities without fueling the start over again of the disease, which is happening in Far East Asia. This morning we had a conference with China, Vietnam, Singapore, and Korea, and unfortunately, in some part of those countries, the infection is starting again after the lockdown because they slow down the social distancing without activating an extensive strategy of tracking. So at the end of the day, we have to develop this strategy.
Just to follow up, Walter, thank you very much to make that clear, especially with the test and tracking for healthcare professionals who have been tested positive once. Would you recommend at this moment already to test twice again? I see now that in many healthcare systems, GPs, people working in home for the elderly, but also nurses, once they had corona, they stay for 24 hours at home, but then they regain work again because there's a lot of social pressure to do that. Would you agree that we need to have in place a way of assuring that they are really not infectious through two tests after the moment they had their first positive scoring?
Yeah, I think it's very important to do that because it is shown that can be quite frequent that you can be still infective and contagious if you are not checked out like this. So again, the Chinese are doing that, and I think we should do that the same.
So Walter, just a couple of questions more. One, if you look at the chat, Veronique was asking if there were in place a surveillance system before COVID. If you could just give a quick answer on this. And then there is another question, quite long, regarding the scientists working on this world pandemic situation. If there are some data sharing channels that have been created and how these are used. So I don't know if you read these questions.
I read them. So the first, actually, we had a very, very good and sophisticated surveillance system for influenza in Italy, but unfortunately, we couldn't use it because at the beginning it was a kind of chaos, you know. So certainly it added some information, but essentially the information that we developed was specifically planned and executed for coronavirus. And now we have a quite sophisticated, it's possible to access this. Sabina, if you want to give them the address of the Istituto Superiore di Sanità, they provide very good infographics. They are in Italian, but there are some summaries in English, and they are incredibly good. I'm sharing worldwide, and they are quite appreciated because they are both very explicative and detailed. Concerning the collaboration, first of all, the first results that we achieved, that the chief scientific advisor of the government was to have a special authorization by the most important publisher to be open. This was achieved. So the most important journals in the world agreed to publish freely, so everybody can access, Lancet and other sources of information for free. While we have not yet a mechanism for making public the discussion that we have in this weekly conference, which is scientific advisors. There are general information, but they are still somehow not public. But the scientific collaboration and the result of scientific collaboration that can be published is already available worldwide.
So thank you, Walter, really very, very much. I think it was very, very interesting. And we are going, there are more than around 80% that now are connected, listening to you, and I had very good comments. We will register this presentation, and I hope that this can be useful for all the persons that are now working on this issue, and also for all the students that are working on this topic. So thank you very much, and tell them that all the people here in Sant'Anna are really would like to help him in everything we can. So
thank you very much indeed. Bye-bye.
Bye. Professor Lopalco is another very relevant scientist working on this topic, and he is a professor in University of Pisa, and now he is in charge of helping Puglia region in facing this emergency COVID-19. So really thank him to find the time to be with us today and to tell us his experience in his work during these last weeks, considering especially the perspective of a region, of a very important region like Puglia. So I give you the floor, Pierluigi, and thank you very much for being with us today.
Thank you, Sabina. Thank you for the invitation. Very happy to be with you today. And as you said, I'm now involved in the regional response to the epidemic. At the very beginning of the crisis, I was a bit more involved in some communication activities, in the sense that with a bunch of other scientists at the very beginning, I think we played quite an important role in warning the national and the regional authorities on what we thought was going to happen. And I think this was an important experiment, because I think for the first time in the recent history, many of the political decisions were based on some scientific evidence. And since the beginning, both national and regional authorities started to base some decisions on scientific advice. I think this happened because they were very scared on what was happening. They were absolutely blind on what was going to happen. So they relied a bit more on science because of this very reason. And then, beginning of March, I started my new role here in Puglia region. Puglia region is in southeast of Italy. It's a quite large region. It's almost 4 million inhabitants, and is in southeast. It means that the pandemic wave started to hit our region later than in the north. And this is a quite important topic to discuss with you, because what I want to discuss with you is some epidemiological issue. I'm an epidemiologist, so this is my topic, and how is important communication and evidence-based communication in facing this kind of crisis, because again, since the beginning, I was involved both at national and regional level with a quite intense communication activity. The first thing that we should learn from this crisis, it is that communication is very important. And if I may highlight a small mistake by the government in communication is the fact that most of the communication, the official central national communication, was somehow limited to a sort of daily bulletin. It was a daily bulletin made by the civil protection. It was just saying how many new cases, how many deaths, and how many people was finally cured and was healthy. So every day at 6 in the afternoon, there was the entire press community in the country that was waiting for this bulletin. Why I'm saying that this is a small mistake? And this mistake is again happening here in my region. The mistake is that when you communicate epidemiological data to the press, you are thinking as but they are thinking as journalists. So what does a journalist matter for? It is the news. So they are trying to extrapolate from epidemiological data a news. And what can be a news about a number? The news can be today there are more cases than yesterday, or today there are more deaths than yesterday. And the day after, because this is a surveillance system, probably you have less cases or less deaths than the day after. So the day after, they make the news. Today we have less deaths. And then the day after, oh, it is not true. So they are not telling the truth because today we have more deaths than yesterday, and so on and so forth. It was a quite hysterical reaction to this epidemiological communication. One of the most important hysterical reaction was about the fatality rate. I can tell you that in Italy, every Italian started to be an epidemiologist. They started to learn what is a fatality rate, what is the difference between fatality rate and mortality rate. They started even to understand what is R naught, or what is the importance of incubation period for an epidemiological curve. Imagine that in the Lombardy region, for instance, of course, the fatality rate was very high because at some point, the entire healthcare system was under stress. They started not to communicate the asymptomatic cases because they did not have enough capacity to test the asymptomatic cases. So they started to test only the people having some important symptoms. You can imagine so that fatality rate was absolutely high. It was higher than China. So what was the news? That in Lombardy, they are treating people worse than in China. So you can imagine how politically sensitive start to be this kind of communication. So one lesson learned is that an epidemic like this should be somehow explained, should be told. We should think about epidemic telling, like storytelling, and try to give the press people and also the general community, the lay public, we should give the elements to understand what is happening. Because another potential danger of this, let's say, not clear communication, they asked somehow frantically, when is the peak? When the peak will arrive? And at some point, this peak arrived. Nobody tell nobody. And now that we are in the descendant part of the curve, people are starting to relaxing and asking, why are we still locked down if the peak is already passed? You know? So it is also now an extraordinary effort to tell people that an epidemic curve is done by an ascending curve and a descending curve. And now we are halfway to the end of the epidemic curve. in Italy, we had the first epidemic that started in the northern eastern part of the country. And then from that main outbreak, we had several sparks that arrived in central and southern Italy. So in the central southern part of the country, the epidemic started a bit later. And starting later, the dynamic of the epidemic was completely different than in Lombardy. So when you are communicating the overall number at national level, of course, the overall number is mostly driven by the cases in Lombardy, so that by the outbreak in Lombardy. And these numbers tell very little about what is happening in the rest of the country. I think it's similar to what happened in Wuhan. So Wuhan is Lombardy and Hubei is Italy. Now, if compare a bit the population size, what happened in Wuhan was completely different in what happened in the rest of Hubei, and it is completely different than what happened in the rest of China. So this kind of communication was not, let's say, governed by and driven by the central government. And these led the press and the public opinion to make some very, let's say, original and fantasy reconstruction of the epidemic. As I told you, a lot of mathematical models started to pop up everywhere. Even professors of mathematics in secondary schools that were at home, they had not so much to do, started to produce a mathematical model. Not only produce, but publish a mathematical model. So what is the use of mathematical model in this kind of communication? It was another effort to explain people that mathematical models are models. They are not the reality. They are not a picture of what is happening. So it is very important not to use a mathematical model to make a forecast. Last week, I saw a quite important study center that published a mathematical model with a table indicating the day of the end of epidemic curve region by region. So you can imagine that I started to get hundreds of phone calls of people saying, is it true that on the 8th of April, the epidemic will end in Apulia? So you can imagine what does it mean. And it is very important to explain that mathematical models are useful for planning. For instance, in my experience, we used a normal SIR mathematical model to plan the hospital beds and the beds in intensive care in our region. So we made a planning forecasting for the 25th of March, 2,000 new cases, cumulative cases, and we make our preparedness plan in the hospitals based on that number. Fortunately, there was the lockdown at the beginning of March, and on the 25th of March, we didn't cumulate 2,000 cases. We arrived around 1,000 of cumulative number of cases in my region. And this was very important because we had a planning, so we had a number of beds that was much larger than what it was needed. So we had, for instance, the possibility also to welcome patients from Lombardy in our hospitals. So models are important for planning and also are important for assessing the effect of interventions. About the lockdown, I can tell you that the lockdown is working. is working well, but it is working especially for those regions that were a bit late in the start of epidemics. So it worked much better for the central southern regions than in the northern of Italy. Because the lockdown, these social distancing measures are very effective, are more effective the earlier you take these kind of measures. I can tell you, for instance, that now we are still recording about 100 or around 100 of daily new cases, but most of them are in elderly homes. When you have clusters in elderly homes, in large epidemic that is also including community spread of the virus, you probably miss these spots. When you have the lockdown, you have no more community spread clusters, community spread outbreaks. You do not have one community that is entirely affected by the disease, but you still have big, important clusters in these communities that are, of course, made by very, very fragile population. So we are still experiencing these outbreaks, and now we are unfortunately learning that these are the communities that should be made, let's say, under a safety belt when the epidemic starts. So unfortunately, managing this kind of outbreak, it is really learning by doing, and especially learning by observing what is happening in those regions when the epidemic started earlier. Another big issue about managing and communicating what is done, it is the issue of testing. I heard the part of the previous presentation. You already asked about the testing policy in Italy. Again, this was another topic of political debate. One region made 50,000 PCR tests. Another region made 100,000 PCR tests. Of course, the region that made 100,000 PCR tests are showing this as a flag of efficiency, of good management, and of course, it is a political flag. So making PCR, it is not only a mean for controlling the outbreak, but it is also a mean of political propaganda. So I was talking about testing. Consider that when it comes to testing, we have also, and I can tell you at regional level, I don't know in the rest of Italy, but I think that there is something similar also in many other regions. A very strong pressure from some group of people. First of all, healthcare personnel. So healthcare personnel is considering testing as a sort of disease prevention. I think that testing for several healthcare professionals is a sort of Tavor, of Xanax, is an antidepressive, the sense that getting the test makes some relaxation that you are negative. But we are really fighting this pressure, because we have the pressure from the healthcare personnel that they want to be tested, all of them. So you can imagine, we are talking about, in one region, we are talking about tens of thousands of people that want to be tested once a week, at least once a week. Irrespective of the fact that in that hospital you are dealing with COVID people, patients, or you are in a hospital that never visit a COVID patient, or you are in a community that do not have one single case of COVID. They want to be tested because they want this kind of, I don't know, they want to be relaxed about the fact that they are in the hospital and the people they are working with are negative. This is the reason. So it is more psychological than, of course, scientific, because our policy is very strict on testing, also for healthcare personnel, because we are putting in place a test and track policy. So we are trying to identify as soon as possible the suspect case. So we test the suspect cases, we track the contacts, we isolate, we quarantine the contacts. And if the contacts are asymptomatic, we don't test the contacts. If the contacts are also polysymptomatic, they have very little symptoms, we are testing them. And for healthcare personnel, we make an exception because the quarantine for healthcare personnel lasts for asymptomatic healthcare personnel lasts 7 days instead of 14. And at the 7th day, we test the asymptomatic healthcare person and we ask them to go back to work. Of course, after negative testing. After quarantine, everybody can go back to work. So I think that we are putting in place a quite extensive testing measure and testing strategy. In fact, in our database, we have a very large part of asymptomatic and people with very little symptoms that amount of more than 35% of our positive cases. So more than 35% of our cases are either asymptomatic or very, very mild symptoms. So it means that we are putting in place a quite good strategy for testing, but this is not enough. I can tell you this is not enough. I'm attacked every day, but a lot of people, a lot of my colleagues in the university that they want to get tested every week, everybody. So this is an issue. And now the next issue with the testing is serology. I also heard Walter that talked about serology. I think that serology should start, but should start at a very precise moment of the epidemic. I can tell you that if I now make a large serology testing in my region, we have today more or less 2,000 cases in a 4 million region, inhabitants region. I think that if I start now with some serology strategy, I will find very, very little positive fraction in the population because there was very little community spreading of the virus. Instead, we are starting with some serology strategy in the healthcare personnel. And this will have a duplex finality. It will be, firstly, to make them more relaxed. So it will be the Xanax that they are going to ask. Secondly, we can effectively understand a bit more on what was the circulation of the virus in nosocomial, in healthcare settings. So now understanding the susceptibility of the population is a topic of importance. And again, this is now the main issue that is investigated by the journalists. And so they are now very expert on what is IgG, IgM, Ig total, and raising of the IgG curve, sensitivity, specificity of tests. They are getting very expert on these topics that I think very, very little people before the pandemic even know the existence. And I wanted to spend just 1 minute, and then I pass the floor. I give you the floor for your questions. The exit strategy. For the exit strategy, there is also it is also a topic on top of the news. How, when, what is a safety exit strategy, and you can imagine this is a very sensitive issue. Restructuring the production world, the productivity, the farms, the industries, to make a more safe working environment. It will be not simple, and at the same time we should be very, very sure that in every and each region we have a surveillance system that is so sensitive to catch an early signal of a restart of a second pandemic wave. Because after the reopening, when the lockdown will be lifted, of course, we will have some potential second wave. It will be mathematical if we don't have a very good system to test, track, and isolate and treat the people that need cure. But we have many lessons that we have learned. Some of them I already told you. So I think that this is my main message for today, and I'm happy now to answering your questions.
Luigi, it was really interesting, your comments. I would like to ask Anna Maria to please present the questions for you that we collected from the HealthPros students, and then we give the floor to the chat questions. But I would like the people that are writing on the chat to put their names if it doesn't come out. For example, I have just a number, or a phone number. I would like to have the name of the person that are doing the questions. Thank you. So, Anna Maria, I give you the floor.
Okay. For Professor Lopalco, we have these 3 questions. The first one is, in the COVID-19 outbreak in Italy, which information is used by whom to make decisions on quarantine measures of the general public, and who generates this information?
So I maybe it's better I reply to this question. And of course, I can tell you what happened here at the regional level. And we have quite a lot of information by our surveillance system. Again, this is another lesson learned. We started to make our information system during the outbreak. So it was like building an airplane when it was flying. It was not easy, because at the same time we had to fill the information need by the central government. So they had this central surveillance system that, of course, we had to fill with information, but we needed much more information at local level to track the chain of contacts, so the epidemic chains, to stop the epidemic chains, to see if there were some super spread events. And we managed also to catch some super spread events, especially in the hospitals or in these nursing homes. So yes, we need a lot of information at local level, and to do that you need a very good surveillance system, and most importantly, okay, the app, the IT can help, but without a good network of people working in the field, public health people working in the field, knowing the territory, knowing well the social web and what is happening in each and every community, I think that there is no app that can replace the work of people in the field. So you need epidemiologists, trained epidemiologists in the field to track and chase every epidemic chain. So the question 2.
Okay, the question 2 is, in Italy, as in most other countries in phase 2 of the pandemic, the reported cases are those that test positive for coronavirus. At the same time, it is well known that due to the policy of testing only symptomatic cases that require medical attention, there are many more people who actually are infected, but mostly asymptomatic. Speculation began to arise as to the true number of infected people. Is it important to know how many people or what share of the population actually contracted the virus? If so, why is this important, and how could these estimates be made?
Okay, yeah, we partially answered this question. So it depends on the phase of the epidemic. If you are in the full exponential growth of the epidemic, I barely think that any surveillance system can catch asymptomatic cases. But in the first case of the epidemic, so when it is very important to track every single case and to stop the connections of the epidemic chain, I think this is very important. I told you that we have 35% of our positive cases that are asymptomatic or with very mild cases. Some of them become symptomatic, some of them become severe cases, but now we have also the possibility to treat some cases with very mild symptoms with hydroxychloroquine, azithromycin, and other drugs that eventually can stop the evolution of the disease.
Okay, the third question. Was there a call for scientists to create inputs on how to guide the country response? Was data liberated for extra governmental actors? And if yes, what inputs were used? If not, do you think it would have or could have a better response?
So there was no a national call for this kind of activity, in the sense that, for instance, I was called here in Apulia region just with a phone call by the governor that asked me if he wanted to join the task force because they needed an epidemiologist and probably there was not enough capacity at the local level. So, and it was also because I'm native of this region, so I'm home in this very moment. But there was not a call for scientists to go in the control room of the regions and provide data for the community, for the scientific community. But consider that the data that are provided daily to the central level are open access. So there is a quite good database, national database, with, of course, limited information, but they are very good, for instance, to allow for some modeling by independent groups.
Thank you very much for these answers, and I would go back a little bit to the two questions I see on the chat. The first one regards what do you think about testing all GPs and people and nurses home like Veneto region did? Could you give us your ideas on this, your opinion? And then the second one, well, but let's go step by step if you want to give an answer to the first one.
Okay, very simply, we are testing entire nursing homes and entire hospitals when we have an outbreak. If there is a local outbreak, we are making some extensive testing to healthcare personnel and people, of course, staying in nursing homes. I think that if there is a lab capacity, this can help to eventually detect early cases. I can tell you also that asymptomatic cases are also detected, but are not that much, and many of these asymptomatic cases in few days become symptomatic. So you can detect them a bit earlier, but otherwise, if you test only the symptomatic cases, sooner or later you catch them.
Okay, thank you. And then there is another question regarding going back to the topic of communication to population. So the question, the synthesis is, do you think that it's better or worse for people to be extra aware of the situation? I can think that on the positive side, measures like that of social isolation might be widely spread and eventually more effective. On the other hand, general fear might influence in the compliance of authorities' indications. What do you think?
I think that social scientists will answer this question very soon. My personal opinion, and this is just an opinion, is that in Italy, I believe that the fear effect worked. In the sense that once people started to be relaxed because of the descending epidemic curve, the day after you start seeing a bit more people around. So I think that these also the impact on the social media, the impact on the TV, it is very important to keep the attention very high. Without this high attention, you start seeing people relaxing a bit more.
So now we have some questions from your student from Pisa, Professor Lopalco. So here's a student from Sant'Anna Medical School.
I just wanted to add something more on the serology, because there is the possibility of some cross-reaction between the SARS-CoV-2 antigens and other coronaviruses. So some tests can react positive, but they are just reacting because you had a cold a few months ago. So this is tricky, and that's why now we need to pilot very well and to see if the presence of IgG is a real IgG very specific against this coronavirus and not other coronavirus, and if they are protective. Over.
Okay. Then there's the other two quick questions. Are viral samples currently being shared nationally and worldwide to track the evolution of the virus?
My answer is yes, but I am afraid that some big laboratories are not sharing the whole bunch of information. Sorry to say, but I think that this is a bit happening, because you know now that there is this fast-track publication on very important journals, and I know scientists in the academy that would kill their best friend to publish in Science and Nature. So I'm afraid that not all the data are shared in the international community.
Thank you, Pierluigi. Your answer is really a very good answer. And then let's do the last question. So why was it impossible to use existing health information system, flu one, for instance, for COVID-19 pandemic?
So the information system for the flu was really tailored for the flu. So it was good, but was not very suited for the new coronavirus. So there were a lot of information that were completely useless, like are you vaccinated? Which vaccine are you used? Are you vaccinated the last year? So a lot of this information were useless, of course, and some information were lacking. For instance, about the contact, what was the probable contact, and the origin of the contact was the key for understanding when and from where the virus arrived in one community. So the COVID-19 requires a specific surveillance system. I'm quite sure about that.
Thank you very much. I give the floor to Nick. We have just 2 minutes. If you want to add something, Nick.
Thank you very much for your very clear presentation. And explaining even further how we have to be very careful on how we apply the testing strategy and also the impact of communication. Very small question. I noticed you use the word exit strategy. I see in other debates with WHO, we prefer the word transition strategy. Taking the communication in mind, would you agree that a transition strategy would be, for public communication, a better word than exit strategy, which kind of assumes that the things will end?
I fully agree. And so it is also a matter of communicating in English that now it is not my first language. I agree that, for instance, in Italy, we are using a phase 2 strategy. So we are calling that phase 2. So meaning that it will be a phase 2, phase 3, and probably phase 4. And but I agree that it is not exit, it is a transition. Fully agree.
Thank you very much. Success with your work.
Thank you.
Thank you really very much, Pierluigi, for staying with us. It was really very, very interesting. I think we learned a lot from your comments and suggestions and your experience. So thank you for being for us. And just a few words to introduce you to Andrea Bellardinelli. He is responsible for new technologies and information system for the Tuscany region. So since this pandemic, COVID started, he has been fully involved in the task force of the Tuscany region. And I think he will present his experience, especially giving us an idea of what we could put in place regarding new technologies and information system to help in facing this emergency situation. So I give him the floor and I really thank him to be with us, because it's really a difficult moment, and to be sure they could get some time for us, it was very difficult. So thank you for being with us, and I give you the floor, Andrea, and thank you.
Hello, can you hear me?
Yes.
Thank you very much for this invitation. Hello to everybody. I will show my face, but sorry for my hair because the barber is closed. So I will show you a little presentation of what we have done related to the health information system. As you can see, this is the presentation regarding the health information system to cope with COVID-19. Just a little introduction. Who are the stakeholders of this activity? The stakeholder was the crisis unit chaired by the president, the regional task force for COVID, the national health authority, because we are linked very, very strong with the National Institute ISS and with civil protection, and obviously with the regional health agency. All the action that we lead is related to the regional ordinance. As you can see, every day our president make an ordinance. So the scenario change very, very rapidly. Just one single question. On February 21, the first order was, please beware of people from China. Now, today, the last order was, the enemy is in our house. So we need to construct a strong and robust information system to deal with this new scenario. What will happen in the last month? We had to provide a solution for over 40 hospitals, many operators, 3.7 million citizens in a very, very, very few time. In the map, as you can see, there are our 40 hospitals. And in the next slide, you can see what happened in various parts of the region. The guideline that we follow for the development of this health information system was quick, simple, and robust solution. No spot purchase, only contract already active, because we have no time to purchase a new solution, to make a public tender, and so on. We need to reduce the learning curve, because we don't want to have an impact on our operator. We try to build a solution that can also be used in the future. This part is very hard, but we need in consideration that we don't want to buy system that after this pandemic we need to put in the basket. And then we work with a team of very, very few people, lean and well committed, because we need a short chain. We don't have time to have a discussion on each task. This is only for you an idea that at the beginning of this pandemic, we try to draw. We start all the system from the positive people. We link many microbiology laboratory, public and private, and we try to start a very strong flow in order to catch all the positive people, both in hospital and on territory. The actors that participating in the mitigation strategy was hospital, laboratories, public health department, community facility, special continuity care unit. I will speak about in the next slide. General practitioner and pediatra. The emergency number 118. Tuscany region as a stakeholder, and measure, police, force, prefects, and so on. We work on regional software platform that we have integrated with the aim to providing the maximum possible support to the operator and patient. So we start from the test, the positive people. We transmit this data to the hospital network, and then all the information are integrated in the prevention information system, in the continuity of care system, in the at the home care assistant and special unit for continuity of care. And we introduced two new apps, the app After Droid and the app A Casa in Salute, that, as you can see in the next slide, are very, very useful to follow the patient at the home. We try to design a very, very strong big data analysis platform. And we use all the existing information flow for the real-time flow development at doc. So in the slide, you can see the named RFC are the existing flow, real-time flow. We developed a special JSON for non-expert. The JSON is a simple format to exchange data, because we have no time to spend in very difficult and strong integration, but we need the data, real-time data. And we develop a special JSON for the test, for the ward bed information, and also for the territory information, for the patient at home. This is just a simple code. As you can see, it's very light and useful to generate information for the machine. At the beginning of the pandemic, we try a very difficult, we find a very difficult situation in our laboratory. Many samples come with a continuous flow without information about the patient. All the test was put on the machine, but the technician spent more time to introduce the patient data. So we developed in each laboratory of the Tuscany. Now we have 12 laboratories on this platform. in order to ease the reading and the real-time transmission of the report for the COVID diagnostic test. What mean? Mean that the technician don't spend time at the telephone to communicate the diagnostic test results. But each people from the 40 hospitals of our network can use the web interface to know if a people was positive, the red one as you can see, or negative. At the beginning we work only with a single Excel sheet file because the number of the case was very small, and from the laboratory all the information come with Excel. But as you can see, after only 10 days and 20 days, the number of cases, the case is the blue one, and the number of contact, the people that was in contact with the case, grow very, very exponential. So it's clear that without a health information system, we don't manage the emergency very well. This is a dashboard that we produce for the preventive department in order to have just with a look of the eye the situation. As you can see now, this is of yesterday screenshot, but we have about 4,360 cases, positive case, but the contact is very, very much. So we are able to trace all the case, all the people, the patient at home in quarantine, all the people in our hospital, all the people in elderly housing, okay?
Nursing home.
Okay. And the number of the death. What means this dashboard? That each people, each operator of the department from his chair can view what is the people that are not contacted up today, how many people are contacted from 3 days or from 5 days. This is just, sorry for the box, but I needed to cover the real information of the patient. This is the case card. All the cases are inserted in a database, and this information is very useful for pediatric medics and also for the direction of the health local agency. This is just an example of the contact card. So we put this new dashboard in each row where we can view the state of this contact. So if you look, there are many red lights that mean this contact is not contacted from our health system from this number of days. Another flow from the patient, not only the positive case from a laboratory, come with the general practitioner. So the general practitioner can enter in the system and can make a signalation, can write a new case that he knows. What happened tonight? As you remember the slide before, this is the final situation of the all case and contact in Tuscany. And as you can see, the epidemiologic test find many contact and case also in other regions. So we are able to catch the information from all the people that was in Tuscany, that take a train in Tuscany, that take an airplane, and so on. Another problem was related to all the Italian people that was outside Italy. So we put on a system to make a auto-signalation of the case. In this case, with email and also with WhatsApp, they receive all the preliminary information regarding to the at-home isolation. The last frontier was the territory. So all the equipe of the name was USCA, Special Unit for Continuity Assistance. We developed a special card where all people was inserted during the domiciliary access. This is just a sample of the dashboard. If you look here, we define a special name for the activity at home for COVID patient. So we have all the recording activity of our team at home. We also make many measurements at home, cardiac frequency, respiration, saturation, oxygen saturation, temperature, and so on. And also we detect which is the symptom of the people at home. In order to facilitate the work at home of the keeper, of the people that go at home, we developed a special app. The app is very simple, as you can see, and all the program related to the authentication is made by a simple QR code. So the patient is inserted in our system. We print only una tantum, only the first time, a QR code. We put the QR code on the table in the kitchen of the patient, and so the people, our people that go to the house, simple make a photo of the QR code and then insert simple activity. It's a very simple app, but it's very useful because our nurses are not the time to go back to the office and put the registration of the activity in the program, in the software program. So we need to catch up the information in real time at home. The other solution that we developed was a special app for all the people that stay at home. Not only the positive COVID, not only the isolation patient, not only for quarantine, but for all the people in Tuscany. And this is the same frame, and in autonomous ways for the people that are able to do that. All the patient, all the citizen can make a simple survey and then can transmit every day as you want all the vital parameters. This is the dashboard that are very useful to manage the patient at home, the citizen at home. As you can see, sorry for the name, you can see that one patient have the fever, one patient have a very low saturation, respiration, and so on. And an automatic alert can be shown on the video. At the end of this information system, we produce a very, very useful big data analysis platform that we use each morning in the crisis unit in order to take control the COVID test, the access of the emergency services, the activity in surgery, and also all the real-time situation of the ward bed in intensive care, in sub-intensive care, and so on. I will show you just a few images in order to understand how it's very important to have all the data together in a unique system. This is the famous card of the pandemic. This is the number in real time of the positive people, and this data come in real time from each laboratory of our region. So we can take control of what happened. We can decide if this forecast reach too many high number in order to set up a very important responsive ward bed in hospital. This is another view of the information coming from the test. We are not working on the number of the tests. We don't believe on the number of the tests, but we believe in the number of the tests related to the inhabitants, the number of the inhabitants. The real problem in Tuscany was in the northwest part of our region. The other one doesn't have a really emergency situation. This is only one of the possible analysis from the COVID test. This is make attention, male, stay at home because the male are more involved related to the female sex. Another information, very important information, is related to the emergency service. This is a real time. We catch this slide 10 minutes ago. This is the real number of the people that are now in our hospital at the emergency services. So as you can see, we have the red one dot where too many people are in this hospital. So we can arrange transportation with the emergency car to another near hospital. Take a look at this. This is the real-time access information at the emergency. As you can see from the prior level, we observe a very, very low level. Each people are healthy. But at this time of this room, you can see what happened after one ordinance. The first one was close the access to the emergency. There was a little curve, and the other one was close all the normal activity. So only the red one, the real emergency, continue to access to our emergency. Typical cardiological, heart attack, ictus, and so on. This is another interesting data related to all the activity. We decided to close all the election surgery, and this is what happened in all our hospitals. Another, sorry for the Italian slide, but we work also on electronic recipe, and we was the first region in Italy to send by SMS the electronic recipe number in order to avoid that the people go to the general practitioner ambulatory and with SMS can go directly to the pharmacy. This is just to show you that we need a very, very simple, robust JSON architecture, but we need also to monitoring what happens. So this is our system to understand if each laboratory work well, send the data, we don't lose data, and so on. And this is the same relevation related to the World Bank. Next step, we are just working now on a special ordinance on Monday morning, a new ordinance for the president introduce the televisit. So this is the new scenario, the new revolution of our health information system. Thank you very much.
Thank you, Andrea. Thank you very much for your presentation. It was interesting to have an idea because we discussed a lot also in the previous presentation regarding the data that you need, and that in this moment is really relevant to be evidence-based. So it was important to have an idea of where these data come from and how we are able to collect them and how we are managing these data. Oh, I think we went out of time, so I think we just have a one or two questions or more. So Anna Maria, do you want to select just one question?
These are the two questions for Andrea. One virtual primary care service is already in place before COVID in Italy, and if not, what needed to be adopted to introduce these services? If already in place, how has it been possible to monitor the uptake and effect of these services in detecting following heart patients? The second one is, do you think there will be any longer-term positive impact on the Italian national system from the situation? For example, the need to work differently might have led to quicker adoption of new technologies, which will be beneficial in the long term. And I stop here.
Because I think we don't have a lot of time, I would ask Andrea to tell us something.
I will be graphic.
No, but especially on primary care services, what the type of contact, because I think this is quite relevant for Tuscany region.
Yes.
Okay.
Just 3 months ago, our region participated in the National Survey of Telemedicine Experience. And we have many experiences in Tuscany, but always related to the teleradiology, telecardiology, teleneuroRadiology, and so on. No service on the primary care. There have been many teleconsultations in this period between hospitals, but essentially related to the chest X-ray, related to the COVID. So we don't have a primary care service now, but related to the second question, as I told before, all this situation related to the COVID has pushed us violently to adopt new solution, new system, innovation. And as I speak before, on Monday morning, a regional resolution, a very revolutionary regional resolution will be issued for televisiting setting in order to set up this kind of services permanently, not only for this emergency period, but for the future.
Andrea, thank you really very much. I think this is a very nice news for Tuscany people that we can adopt this new technology for this type of services. So thank you really very, very much for sharing with us your experience and all your work. And thank you for all what you have done in these last weeks to put in place the information system for the emergency we're going through. So thanks. Alessandro Colombo is the responsible director of the Academy for Healthcare. So it's the training institution for Lombardy region that's in charge of providing training services, training courses for the management, for GPs, for health professionals in Lombardy. So thanks to Alessandro Colombo. That was so nice to find time to be with us today and to collect some interesting views from different stakeholders from Lombardy region. But I give him the floor to present himself.
Thank you, Sabina. Thank you to everybody. Straight to the point, Lombardy is a 10 million people region in the north of Italy, one of the richest regions in Europe. As you probably know, we were affected by the coronavirus deeply and strongly. Out of 10 million people, nowadays we got something like 45,000 patients, positive patients. We've got 13,000 cases hospitalized. And out of this, just to give you a number, we've got 1,300 people in intensive care units. In terms of time, if you agree, Sabina, we can pass to the questions, and I can only add a few things.
Okay, so Anna Maria, if you want to put the questions on.
Can you provide some insight into how the various actors involved have worked together to manage the pandemic to ensure not only the provision of healthcare services, but also other continuation of essential services while maintaining civil order? How decisions were made? What were the compromises? And the second one, crystal ball exercise. If you knew 1 year in advance how the pandemic will develop in Italy in 2020, what would you have done in the healthcare system? 2020 inside exercise. What will the Italian healthcare system look like after the COVID pandemic?
Okay. As for the first question, as you could see, the healthcare system, within the system, I mean hospitals and the classical healthcare system work quite well. As for the other actors, there are two dimensions of this. The other actors are the importance of social services and the importance of the towns and the authorities within the towns was decisive. And lastly, actors are also institutions. The communication and the decisions between regions and the national state in Italy, like probably many other countries, I think can tell us a lot about what's going on in the future. Because there are decisions that cannot be taken without reality. And this leads me to the second question about the future. One of the people said, this time we can take it seriously. We have to take this thing seriously. Here in Lombardy, it's tough, and it's really tough, also personally for me. I lost friends. So when you have to take decision, you have to surf this wave. I give you two dimensions. Otherwise, if you don't surf this wave, you will forget, and tomorrow will be worse than what is now. I think in terms of tomorrow, there are two dimensions that we cannot miss. One is the hospital, is related to the very idea of hospital. Hospitals cannot be longer anymore what they are now. I'm talking about the number of hospitals and the dimension of hospitals. In Italy and Lombardy, in one day, actually in the space of a night, we managed to reorganize all the network and the numbers of hospitals and what they do and what they don't. After more than 10 years talking about doing this, in one night, we managed to do that. Again about the hospitals, the future of the emergency rooms, the futures of the ambulatories, the future of the elective surgeries. We cannot go back to what we were before. And thirdly and lastly, about the hospitals, the connection with the outside. We have to learn that most of what we are dealing can be dealt outside. And probably it's true that we should reduce the number and the intensity of the hospital. But the second chapter, and I'm finishing, regards the personnel. Tomorrow, we cannot deal with the workforce like we did so far. I'm thinking about the recruitment of personnel, the access of the profession for professionals. We have to invest in young people. Now, most of the young people, young doctors, are involved in the situation. And the future has to do with these people more than has to do with our idea of what a hospital is. Secondly, the mix between nurses and doctors should be revised. We are too tempted to medicalize everything. And lastly, the idea of training. We discovered, as it's mentioned in the video, that we managed to train thousands of doctors to do other things. Lots of doctors, orthopedic, geriatric, or even surgeries. They learned how to deal with respiratory disease. So it is possible to break down our silos. It is possible to change the way we conceive the disciplines in medicine. It is possible, in other words, to come back to the idea of caring. It doesn't mean getting rid of the technology and specialization. That's wrong. But it means that the doctor is somebody who's taking care. And lastly, you can learn on the job. So in terms of, for example, university specialization, I think there's a lot to do about this. We spend too much time in keeping young generation out of the hospitals, out of the services, and keeping them in universities. Probably this should be changed. The last thing, again, it's a bit romantic, Sabina, but I think that this kind of task force that we have to establish now, which is different from the task force that we're using to cope with the virus. It must be a task force to rethink the system, should be handled by young people, maybe helped by us, but that is the future. I'm finished.
Thank you, Alessandro. As usual, you were really interesting in your thoughts and your comments. Now, I would like to see from the chat if there are other questions. There is one from Lorraine that says, I have a question regarding the mental health and motivation of health personnel and administrators. Are there clear learnings that can be transferred to other countries?
Two things. As far as I understand, I see the system in a single perspective. Two things. One thing is probably most important. Most of the people that you have seen, over the interviews, they cried. But at the same time, they cried. How can I say? They cried because they understood and they're together. They are moved to something which is related with their own tasks. So the stress, there's a psychological stress which is bringing back to the vocational of the institution. Secondly, there's also a dramatic situation. As you probably know, 2 nurses committed suicide over the last week in Lombardy. And that is dramatic. So people are resisting, adrenaline is working hard, but we have to establish a system of support. And this is what we're doing. We are organizing a system for helping this doctor. And this is, again, is changing the role of psychologists within the hospital.
So thank you, Alessandro. I would like Nick, if you want to do a question or comment on what Alessandro told us.
No, well, thank you very much, Alessandro, for what you shared with us and taking the effort of making the video. I think it's very impressive. And what is very touching is to see the kind of professional ethos that comes up. As you said, people have tears in their eyes, but it also means that you go back to the root of what medicine and nursing and caring professions are about. And I think it's a very positive sign that already in this stage, still being in the period of the pandemic where a maximum input is asked, that you start reflecting on what consequences that should have on the way how we have organized our professions and how we are training them. So it would be very good, and not at this moment, at a certain moment, to learn about especially all the task substitution that has been taking place between different specialties, between nurses and doctors, because it would be an important lesson to see where the boundaries would be, because I can see that there must have been a tremendous pressure on everybody who has a nursing or medical career or is an allied health professional to do work, to meet on your oath of Hippocrates and do what you think is the good thing. On the other hand, the mix of competences and skills is of course quite varied, and there is a reason why we have put them in separate training programs and in separate disciplines. So at another moment in time when the heat is somewhere off, it would be very good if we start thinking about how to shape our healthcare systems, also to have this good evaluation of what it learns us on basically the flexibility and resilience of the healthcare professions to scale up and scale down in a way that is necessary to deal with the pandemic. So thank you very much for your contribution.
Sabina, if I may add a kind of slogan, a final slogan, I think what we are learning here is the we spend too much time in organizing and thinking about the system in terms of the supply side. Maybe the virus is teaching us that we start thinking the system in terms of the demand side.
Thank you, Alessandro, for your contribution. Really, I think you give us very strong and important messages. So thank you really very much. And I think that your contribution is really well linked what's next. I would like to give the floor to two professionals, Director of Cardiology and Cardiovascular Medicine for the Teaching Hospital of Fondazione Monastero here in Pisa, and Paolo Valacarne is Director of Anesthesia and Resuscitation Unit at the Teaching Hospital of Pisa. So they are both every day on the field next to patients, and so I think they well can catch from your contribution, Alessandro. And we think that it's, for them it would be more interesting to start straight away from the questions and to in this way make them contribute to the debate. So I ask Anna Maria to start with the questions and let them answer to the important issue that you proposed.
Okay. First question, how much consideration has there been of the impact of the COVID crisis on other less urgent but still important healthcare activities, e.g. cancer treatment, chronic disease management, and what is possible to appraise this impact and try to manage it, or was whole time and energy taken up with managing COVID cases? The first one.
So first, let me remind all who have suffered and died, in particular nurses and physicians, and we too have friends in the northern Italy and also here in Pisa who are facing this threat. This question is truly important because disease epidemiology is still there. So people continue to experience the symptoms of acute myocardial infarction too, also at the time of coronavirus. And cancer patients still need diagnosis and treatment. And you have seen in the graphs of Belardinelli that unfortunately the number of surgeries, including surgeries in cancer patients, have dramatically decreased this time. The focus on this point led, for example, in Tuscany region, as in Lombardy, to the identification of COVID-free focus hospitals, such as ours, which is dedicated to cardiovascular disease care, also to COVID-free areas within large hospitals. Looking behind, more effort should be done on information to population about the necessity of urgent care in case of cardiovascular symptoms. For example, during these weeks, there was a dramatic decrease in the number of acute coronary syndrome, which is partly due to the fear of patients to have access to the hospital for fear of injection. Some infections, some patients have died or have delayed their diagnosis and their referral for fear of coronavirus. So this is a point who has been underestimated. From our counterpart, we tried to face this problem, trying to enhancing the possibility that general practitioners could access the emergency cardiological visits, giving a free phone number to call and have immediate specialty consultations. And also we are setting up a service of televisit and teleconsultations. So at this time we have to think that we must think also at non-COVID life-threatening diseases. Actually, I think that the Western world was totally not prepared to these pandemics, and during last decades, the focus was on cardiovascular disease and plastic diseases and neurological diseases, and also our hospital, as Paolo will tell you, are not prepared from many point of views to these pandemics, for the lack of negative pressure rooms, to the lack of people prepared to this threat in the intensive care. So this is my answer to the first question, while the second question will be answered by Paolo.
In Italy, was there national representation in place for clinical parties before COVID? For example, representation of intensivist doctors, representation of hospitals, capacity? If yes, did the mandate change in the COVID outbreak? If no, were these established in the COVID outbreak?
So Paolo will speak in Italian and thereafter I will translate. He will begin with the premise.
Io lavoro con I malati.
He works with diseased patients.
E vedo tre questioni importanti nella COVID emergency.
And he thinks that in the emergency, this COVID emergency, there are three main questions.
Clinica,
the clinical one,
organizzativa,
the organizational one,
e etica.
And also an ethical issues, which is truly important.
Clinical. Questione clinica è malattia con diversi livelli di gravità.
So from the clinical point of view, this disease has diverse degrees of severity.
E colpisce persone con un diverso stato di salute.
And also the people this disease hits have a different clinical background on different degree of severity of previous morbidities and comorbidities.
Stato di salute significa riserva funzionale.
So the baseline health status or disease status is the baseline functional reserve.
Quanto maggiore è la gravità della malattia, tanto maggiore è necessaria una riserva funzionale.
So, if the COVID infection is severe, to be faced, it needs not only of the clinical effort, but also of a baseline individual patient functional reserve.
Se la malattia è grave, chi non ha riserva funzionale muore.
If the disease is severe, so the lack of a functional baseline reserve, it is a truly life-threatening condition.
Seconda questione organizzativa.
From the organizational point of view,
a Pisa, in 20 giorni, 34% dei malati arrivati al pronto soccorso era anziano con comorbidità.
So Paolo, who is the head of the animation unit of the University Hospital in Pisa, tells us that since March 10 up to 30, so the 70% of people accepted to the hospital with the COVID infection diagnosis was older than 80 and had very severe comorbidities.
Tutti questi malati anziani con comorbidità vanno curati solo con l'ossigeno.
So he thinks that this subset of patients need an oxygen-based treatment.
Perché tutti quelli che vanno in terapia intensiva muoiono.
Because with this level of background clinical severity, the prognosis is worse, and the access to the intensive care unit is associated with the paramount number of deaths.
Questi malati anziani con comorbidità possono stare a casa?
So this is a truly important question which deals with the end-of-life issues. Should these people recognized in some way, and should their path be home-based and not hospital-based?
Terza questione, etica.
So the third question, which is a capital one, is the ethic issue.
Chi muore in ospedale di Covid muore da solo.
If one dies in the hospital, he dies alone,
Senza familiari.
without relatives.
Familiari sanno della morte con una telefonata.
So the relatives know of the death of their beloved with a phone call.
Seconda questione etica, la giustizia distributiva.
So the second question is the distributive justice.
Se la persona anziana con comorbidità avesse fatto la pianificazione delle cure, sarebbe venuta in ospedale?
If there would be at the territory level program, this old person with a very poor prognosis would have the destiny, a death in the hospital.
Giustizia distributiva.
Okay, distributional justice.
In intensive care, first come, first served.
So the true reality is that in the intensive care unit, who first comes is first served.
Posti finiscono.
The number of beds in the intensive care units are fixed.
Noi apriamo nuovi posti.
We are opening novel bedroom facilities,
ma sono posti di serie B.
But they are B series places.
Perché ci sono medici meno esperti.
Because the medical personnel is less expert.
Infermieri meno esperti.
Less expert nurses.
Attrezzature meno idonee.
And also technical tools are not at the same level that the original the intensive therapy units.
Allora le domande sono: con quali criteri stabiliamo chi curare in un certo modo?
So the true question, which are the criteria to decide who has to receive which kind of care? Are there these criteria? So this is the premise of Paolo, very strong premise. Then there is the answer to the question.
Ci sono pochi pre-Covid, pochi specialisti in anestesia e rianimazione.
So the problem is that given that the health system is not organized in terms of intensive care units thinking to a pandemics, but thinking to the trauma and to the surgery and to the cardiovascular accidents and so on. Actually, there are a few true intensivists there were at the time of the beginning of the coronavirus pandemic. And also the bed number in the subintensive units were insufficient.
C'è un gap di assistenza tra l'area critica e la polizia.
And there is a truly large gap of assistance level in between the intensive and subintensive setting and the ordinary ward.
Quindi è difficile il discharge.
So it is difficult also the moment of discharge from the intensive care unit. From this point of view, I would add that in Tuscany region, for the decision of the governor, some areas of weaning from the intensive units have been in a very quickly organized in area very close to the hospital, all the hospitals who have reorganized.
Our mandate is changing, yes.
See, the second question is their mandate change in COVID-19 outbreak. The answer is yes.
Abbiamo ridotto I letti post-chirurgici.
So the main collateral effect was the reduction in the post-surgical intensive beds, and this meant that those patients, for example, with cancer, have now to wait for having surgery for the neoplasm.
Per fortuna ci sono meno traumi.
Luckily, the traumatic affection have dramatically decreased for the lockdown.
Il nostro mandato è di aprire letti nuovi di terapia.
So now the mandate is to open new beds of intensive care units. Also, if there are some constraints associated with the manpower and also the technical tools which make difficult this goal. So there is the third question.
Yes, it's the first question. And please try to be synthetic because we don't have a lot of time. We just have a few minutes left. Most institutions and most countries have some type of emergency plans in place, sometimes of general nature and sometimes of specific contingency, such as infectious disease outbreak. In your experience, how useful were these plans? What were the major advantages of having these plans in place?
So my quick answer is that it seems to me that were no planes, and we all have looked at the crowded conferences of Mrs. Merkel and of Mr. Trump, also of our Minister of Health, of Mr. Johnson. And also we can think also at the foolish French decision to maintain the administrative elections. So Western countries had no at all plans to face these pandemics. I do think that now we have to try to draw a quick lesson from these mistakes, because there will be a time for a return to the normality, but this should be based on very careful selection of some steps to go to normality. So the take-home lessons from the hospital to the society is more humanity, more technology as a tool, not as a goal, and protect doctors and nurses to protect their lives, because the Lamberty lesson was that the hospitals were sites of infections, because at the very beginning there were inappropriate choices about the protection of sanitary pads.
Thank you, Michele, and thank you, Paolo, for your suggestion, for your contribution. It was really interesting to have your point of view. I want to give back the word to Nick we will close our session after the conclusion of Nick with the video of the governor, with the president of the Tuscany region, Enrico Rossi. He's not able to be in this moment with us, but he was able to send us a video. And I really thank Letizia Bertoli from the Met Lab that in these last 2 hours was able to the translation in English in this video. And we will be able to present it in in some minutes. But first, I would like to give the floor to Nick for some brief conclusions.
Thank you very much, Sabina. And let me first express, as one of the organizers of the HealthPros program, our great appreciation of all the presenters of this afternoon. I think this was a unique opportunity to learn from how different perspectives people are starting to draw lessons from the way how Italy has been handling the pandemic with COVID-19. So much appreciation of making yourself available and explaining in English to a group of people who are basically researchers, students, what is going on in Italy. I won't try to draw conclusions, Sabina, that would be pretentious. We really have a full richdom of ways how the Italian system is dealing with this. So just some of the elements I learned about the need to differentiate between the different provinces in Italy, relation of being able to respond quickly depending on the governance model. I learned more about how the testing strategy, the test and track strategy is implemented, how the thinking about this is ongoing, what kind of new information comes there. I learned about the way how to communicate epidemiological and scientific knowledge to a broader public and how you are interlinked. This is something everybody experiences, but people will remember in the foreseeable future. And we have to learn how to have a continuous dialogue in a transparent society about what evidence and the health professions are doing and what people, the general public perceives, because we need input from everybody to deal with a crisis as we're facing today. And I very much appreciated also the realization of many of the presenters today, and especially the last presentations, to show how after this we have to rethink how we set up our healthcare system. It's not just improving the responsiveness to a pandemic, but it aligns to the broader story of how do we position hospitals, how do we align primary care with hospitals, how do we position long-term care, and how can we create the intelligence underlying this to help us govern the system as a whole. And that brings me to the big relevance of this afternoon for the work of the HealthPros program, because that's exactly what in this project we're doing in our research. We try to see how to measure performance intelligence, how to build into the governance mechanisms of the system, and at the end, how people are actually using it on a day-to-day basis. And we saw some very good examples what at the moment is setting up. So I feel that the tension and the emotion that lies in the present situation. But as researchers, it's also great to have the opportunity to learn from this natural experiment where we are all the guinea pigs and use our intellectual capacities to learn about it, analyze it in a systematic way, and in that way help us to make our systems more resilient to these kind of challenges. So let me end, Sabina, by thanking you and Anne-Maria and the group in Sant'Anna very much for hosting this afternoon. And I know we will have little opportunity to discuss the whole week. So let me also use this opportunity to thank you for the whole week that was organized. Tomorrow, the fellows will have a writing day. That basically means that they will work amongst each other and will write their scientific papers. And I'm sure that the COVID information will be reflected in the way they will pick up the work over the coming months. So many thanks for hosting this and for an excellent training week, but especially making it so relevant through this afternoon on the response of Italy to the COVID-19 crisis.
Yes, and thank you, Nick, for being with us and discussing with us this such a relevant issue of today. And I would like to ask if there is a last comment from the HealthPros fellows, if they want to add something. Otherwise, I will ask Anna Maria if we are ready with the video of Enrico Rossi, our president.
Buongiorno a tutti. Ci sono alcune lezioni fondamentali che noi possiamo apprendere da questa drammatica vicenda del coronavirus e dai suoi effetti che molti paragonano a quelli di una vera e propria guerra. Non a caso è così forte la metafora bellica nel discutere intorno a questa epidemia. Io credo che la prima lezione sia davvero quella delle scorte. Noi non possiamo trovarci in una condizione per cui per una mascherina, ma anche per dispositivi di protezione banali come visiere, occhiali, camici, ma anche per qualcosa di tecnologicamente più avanzato, come ad esempio i ventilatori, i respiratori, le CPAP, non possiamo trovarci per questi materiali assolutamente indispensabili a dipendere da un altro paese al di fuori dell'Europa. L'Europa deve dotarsi di una riserva di questi dispositivi che sono fondamentali per affrontare epidemie, situazioni di difficoltà e crisi sanitarie, altrimenti noi davvero rischiamo di mandare l'esercito così altamente professionalizzato dei nostri medici, dei nostri infermieri, degli operatori sanitari a combattere una guerra senza strumenti, rischiamo di demoralizzarlo. Il mio primo appello quindi è questo: sia all'Europa a costruirsi una politica industriale a sostegno dei sistemi sanitari e a sostegno delle cure, sia all'Europa a costruirsi una serie di depositi da poter usare nel momento dell'emergenza e nel momento del bisogno. La seconda lezione è che non possiamo assolutamente, di fronte ad un'epidemia, perdere le roccaforti. Le roccaforti intendo gli ospedali, intendo coloro che erogano le cure più sofisticate, le cure estreme, come sono appunto le terapie subintensive e le terapie intensive. Noi ne abbiamo bisogno, dobbiamo averne un numero sufficiente. Io credo che anche qui dobbiamo avere terapie intensive a riserva per certe situazioni di particolare necessità e di particolare bisogno. Posti letto di terapia intensiva che è possibile adoperare proprio quando ci sono situazioni di emergenza come quelle che stiamo attraversando. E quindi posti letto di terapia intensiva che devono stare sotto l'ombrello di una protezione civile nazionale, di una protezione civile europea. Aggiungo che la modernizzazione degli ospedali è assolutamente fondamentale. Innanzitutto i sistemi di areazione impediscono, se sono ben fatti, che gli ospedali diventino focolai di diffusione delle malattie e dell'infezione. E poi ancora i sistemi nuovi di tecnologie avanzate che tutti i nuovi ospedali hanno, anche nei posti letto di medicina, consentono la conversione dei posti letto di medicina rapidamente in posti letto di terapia intensiva, qualora avessimo appunto depositi di ventilatori. Ma per continuare questa metafora, io credo che bisogna esplicitamente dire che se non si possono perdere le roccaforti, perché una volta perse queste sarebbe un disastro, se quindi bisogna guardare all'ospedale come una risorsa fondamentale ed estrema per la cura, bisogna sapere che la battaglia fondamentale si vince sul territorio. Ecco perché è fondamentale il medico di famiglia, fondamentale dotare il medico di famiglia di dispositivi perché possa recarsi a visitare i pazienti. Il medico di famiglia è il primo accesso ai servizi più avanzati, alle cure più avanzate. È fondamentale, noi in Toscana abbiamo visto anche individuare veri e propri alberghi sanitari dove poter isolare e tenere sotto sorveglianza sanitaria la popolazione che è entrata a contatto con persone affette da virus. Sono fondamentali anche le cure intermedie. Sulle cure intermedie in Toscana abbiamo deciso di erogare anche una prima terapia di ossigeno, in modo che si arrivi in ospedale solo dopo che si è percorso una serie di tappe separate nelle quali si erogano cure appropriate nel posto giusto e al momento giusto. Penso che di spiegare questa potenzialità di intervento su un tema così importante, così delicato come quello della salute, ci possa mettere davvero come Europa all'avanguardia. Non c'è nulla da invidiare come sistema Europa per la nostra tradizione, per le nostre competenze, per la nostra capacità di ricerca, direi anche per la nostra organizzazione. Se riusciamo a individuare bene queste tappe, non c'è nulla da invidiare rispetto ad altri sistemi. È bene che noi si continui ad avere tanti investimenti in sanità, tante risorse investite in sanità e cercare di risolvere questi problemi con sistemi di cura più avanzati, più funzionali e più efficaci. C'è una grande lezione sulla quale si dovrà continuare a discutere anche in futuro. Penso che la Toscana su questo tema abbia fatto delle scelte efficaci, innanzitutto la dimensione anche organizzativa di fronte a questa epidemia, una dimensione di area vasta, ampia, nella quale si può governare anche la risorsa ospedale come risorsa estrema, appunto in un sistema di regolazione, di equilibri tra i diversi ospedali, perché nessuno abbia ad essere soffocato, abbia ad essere travolto dall'afflusso di pazienti. Anche questa modalità di governo per area vasta e regionale è una modalità senz'altro che si è rivelata positiva. Gli investimenti nella modernizzazione degli ospedali, ormai li abbiamo tutti nuovi o dove non sono nuovi sono stati ristrutturati, consentono, come dicevo, di avere ospedali più sani e più flessibili anche nella conversione di posti letto verso le terapie intensive, di separare meglio, come si dice, l'area no Covid dall'area Covid, lo sporco dal pulito. Semmai la lezione fondamentale è quella che dicevo all'inizio: noi dobbiamo rafforzare una disponibilità di riserva che dobbiamo mettere in campo di fronte a queste situazioni. È giusto che l'ospedale rimanga risorsa estrema, risorsa efficiente, che nell'ospedale ci si stazioni quanto è necessario e non di più, ma dall'altro è anche giusto dotarci di una riserva rispetto alle cure estreme che l'ospedale può erogare da utilizzare nei casi di emergenza, e dall'altro continuare a rafforzare gli interventi sul territorio, cure intermedie, alberghi sanitari, ruolo fondamentale del medico di famiglia. Quindi, come dire, da un lato la consapevolezza che abbiamo fatto scelte organizzative di investimento importanti e dall'altro anche questo dato in più. Non abbiamo ancora una idea di come intervenire di fronte ad un'emergenza sanitaria. Siamo molto capaci di ragionare in termini di emergenze per quanto riguarda le alluvioni o per quanto riguarda altre situazioni come possono essere in alcuni casi anche nel mio paese i sisma, ma adesso dobbiamo ragionare di più in termini di protezione civile sanitaria e quindi dotarci di strumenti, dotarci di un'industria che produca gli strumenti, dotarci di sale che consentono di avere la possibilità di installare rapidamente le terapie intensive, fare una volta all'anno vere e proprie esercitazioni per questo e poi rafforzare il territorio, perché la risorsa ospedale, per quanto sia forte, per quanto si possa mettere in campo anche una riserva di posti letto di alta intensità, non sarà mai capace di far fronte ad un bisogno che riguardasse centinaia di migliaia di persone, e quindi separare e erogare cure appropriate a cominciare dal territorio.
So, thank you to Enrico Rossi. I think this morning he had the opportunity to do this video for us, and that was promptly produced by Letizia Bertoli. So thank you to everybody that has participated. If you want then after to write some notes to Anna Maria, I'm saying especially to the HealthPros fellows, if you want to do some comments, they will be very appreciated. Thank you for Nick for his participation and leading this meeting. And thank you to my staff that really worked a lot this week putting together, I think, this very interesting meeting. I remember to everybody that we will, this meeting has been registered and we will fix it so that we can put this, be available, and also if you want to use it in your own countries and in different teaching learning opportunities, it will be available. So Nick, I think we can close now if you agree.
I fully agree. And again, molto grazie. And I really hope that we will be able to meet in person in Pisa in better times. We have already tentatively put there September, close to the ESQA conference. So I sincerely hope we will have the moment to be all together in a room and don't be necessary to have a physical distance of 1.5 meters. So thanks very much. Stay healthy and keep thinking.
And stay home for the next 2 weeks.
And stay home for the next week. Take care.
Bye. Bye-bye to everybody. Thank you.
Bye-bye.